So we're going to move on to the definitions of tolerance, dependence, and addiction. So tolerance is a pharmacologic term which is defined by a change in the dose response that occurs with chronic exposure to a drug, and manifests as a need for a higher dose to maintain the same analgesic effect. So tolerance to opioids, this is where patients say, I don't want to take it now because I'm afraid when the pain gets really bad, it won't work. They're talking about a fear that tolerance develops to the analgesic effects of opioids, and that is a misconception, and a misconception that we clinicians can help to correct. So if you gave an opioid naive patient a way too high dose of morphine, you could certainly cause respiratory depression or respiratory arrest. If you gave them an appropriate starting dose of an opioid, they are very unlikely to develop any respiratory depression, but they may develop sleepiness if they were opioid naive to begin with. And about 20% develop some nausea. That also is short term. So both the sleepiness and the nausea wear off within the first 3 to 6 days after starting the opioid. And I've had hundreds of patients who have come in and said to me, I'm allergic to morphine. And I'll say, why are you allergic to morphine? I got so nauseated when I took it. And then it was my failure to explain to them that nausea is a common and predictable side effect that does wear off in a few days as tolerance develops. The same with sleepiness. People will say, I can't take that, it made me, I was zonked, I was out of it. And again, it's very important to explain to people that that feeling of sleepiness is short-term and wears off as tolerance develops. In fact, tolerance rarely, if ever, develops to the pain-relieving effect of an opioid. The vast majority of the time, when someone has been on a stable dose of opioid for pain and they come in and say it's no longer working, the reason it's no longer working is because the illness is progressing. There are more metastatic lesions. There's new pressure on the spinal cord. There's been a pathologic fracture. It's usually disease progression that accounts for the need for higher doses of medication, not tolerance. So I think that's very important for us to understand as clinicians. And then constipation, which is a virtually universal side effect of opioids and has to be prevented before starting the opioid. Tolerance never develops to that. Even tiny doses of opioids can cause very severe and intractable constipation. Even an opioid dose for a major dental procedure can leave somebody constipated for a week, even if they've only taken 2 or 3 doses. So very important that we are hyper focused on that and recognize that it is our job to explain the risk of constipation, which is universal, to patients and impress upon them the urgency of taking the laxative before they start the opioid every day and reporting to you if they're not having bowel movements on a regular basis. Because it's actually, not only does it cause a lot of distress and pain and loss of appetite and function, when bad enough it kills people. We had a patient at Mount Sinai who had opioid-induced constipation so severe that he ulcerated his colon. That's called stercoral ulceration, and became septic and died. So severe constipation not adequately managed is life-threatening. And as I said, analgesic tolerance rarely, if ever, occurs. Worsening pain in someone who was stable on an analgesic regimen is usually due to disease progression and is often confused with addiction and dependence. So what is dependence? Okay. Dependence is a physiologic phenomenon, meaning that if you abruptly stop the medicine, there will be a withdrawal. And let's think about all the drugs we routinely prescribe that we never cold turkey. We never stop them abruptly because it's dangerous. So prednisone or corticosteroids are a good example of that. We are taught to very carefully taper these drugs. And the same with beta blockers like propranolol for hypertension or heart disease. If you cold turkey abruptly stop a beta blocker, you can precipitate a heart attack. The person can very quickly become tachycardic and under enormous cardiac stress. So we're all taught to taper these drugs, and the same is true with opioids. So dependence, the definition is development of withdrawal following a significant dose reduction or administration of an opioid antagonist, or an abrupt cessation of the drugs. And you can develop dependence after fewer than 2 to 3 days of opioid therapy. And doctors and patients often mistake that for addiction. And it is not addiction. It is a signal that the person has to be tapered. So in general, the teaching is to taper by 25 to 50% of the dose every 1 to 3 days, depending on whether the opioid you're using is a short action, immediate release, or a long acting extended release preparation. So dependence is just about the development of a withdrawal syndrome with abrupt cessation or a major dose reduction. It is not the same thing as addiction. And what we do when that occurs, if we need to get somebody off the opioid, is taper. And just as we would taper prednisone or other corticosteroids. Addiction, on the other hand, is actually a psychiatric and physiologic diagnosis, and it is diagnosed through the presence of compulsive use of a drug despite self-harm or harm to others, uncontrollable craving, and loss of control over use of the drug. It's a maladaptive pattern of behavior, and the data shows, despite all the hysteria in the United States, that patients who don't have a prior history of substance use disorder, and that can include alcohol, cigarettes, other illicit drugs, and have a medical disorder like cancer causing pain, that the likelihood of developing a substance use disorder is extremely small, under 5%. And so what does that mean for us as clinicians is we need to know, have you ever had a problem with substance use disorder or addiction in the past? Anybody in your family had a problem with that, or your friends? Do you drink? Can you control your drinking, or do you need a drink, an eye opener in the morning? And do you smoke cigarettes? Because prior dependence on a substance predicts future dependence on another substance. So the major risk factors for the development of addiction, or as we now call it in the States, substance use disorder, are a current substance use disorder. Are they already buying street drugs and using them? Do they have a past personal history or a family history? So a family history not only increases the likelihood that the patient, him or herself, could develop it, but it also creates a culture. The person grows up and lives in a culture where substance use disorder may be the norm, and a high-risk social environment. So for example, a teenager, for example, who goes to high school, all of whose friends are taking substances, is at much higher risk for developing a substance use disorder when you treat her for her medical condition than someone who is not in that social environment. So you have to understand not only the person's individual history, their family history, and their social environment to assess their risk for substance use disorder. There's a syndrome that's called pseudo-addiction because it looks like addictive behavior, but is actually due to physicians' failure to dose appropriately. And I can give you a story of that. We had a 23-year-old with acute leukemia, AML, acute myelogenous leukemia, who had excruciating bone pain from a bone marrow packed with immature neutrophils, blasts. And she came to the hospital with enormous levels of pain. And they were giving her Tylenol with codeine, acetaminophen with codeine for the pain, 2 tablets every 6 hours. And she would get really minimal relief with those 2 tablets. And by the time 2 or 3 hours had passed, she was screaming in pain And the nurses would say, no, Kate, you can't have any more. You know you can't have it for another 3 hours. And there were two problems with the prescribing. One is the amount of opioid was insufficient to get the pain to a tolerable level. It needed to go from a 10 to a 4 or a 5, and it went from a 10 to an 8 at best. And B, the clinicians did not seem to understand the half-life of the drug, the opioid. The half-life is about 3 hours. So after 3 hours, there was no opioid remaining in her system, which is why she would get agitated. She was labeled as a manipulative drug-seeking patient in my hospital. With a devastating acute leukemic diagnosis, until finally the palliative care team got called. We switched her to an appropriate dose of morphine and dosed it every 3 hours around the clock, because that's how long it lasted in her, and her behavior changed dramatically. She later said to us that the most devastating aspect of getting this leukemic diagnosis was being treated as a manipulative drug seeker by the doctors and nurses taking care of her. Most of whom were young, were her age. She was 24, 25. So the medical students, the house staff, the nurses were about her age, and began treating her as if she was a manipulative drug seeker, because they did not understand the pharmacology of the drug and did not understand how to properly dose it. She eventually was cured of her leukemia with a bone marrow transplant. She needed palliative care at her bedside for hours every day to get through both the acute induction therapy and the side effects of the treatment, but she's now fine. And as I said, the biggest trauma associated with this diagnosis was how she was treated by us, by the medical professionals, who didn't know how to properly manage her pain and blamed her rather than figuring out how to manage it effectively.